What are you wearing? Holy smokes. Good morning. Good morning. Welcome to day 3. I feel like as the days go on, the morning sessions are harder and harder to get out of bed for. So thanks for coming. I think we're making it through. So we have no ties to any drug makers. This ERCast Live is going to be called the Dilaudid debacle. Not to reveal my hand, Drew's got this shirt on. I want to give you the opportunity to make your points first, so that then we can all see how foolish those ideas were. So acute pain management in the ED, the case is simple. You're at the desk trying to do 5 things. They keep saying room 8 hurts. Can they get something for pain? Can they get something for pain? What order do you put in?
Yeah, so we're talking about past non-opioid medicine. Let's just clear the air on that one, right? Like we've moved past that. We're going with opioids.
You've tried everything else to make them and the nurse be quiet, and you're having to reach for something that's not, you're looking at a controlled substance.
Yeah, sure. So my approach to treating pain on these patients is pretty simple. I like morphine. I think morphine's a great medication, and the beauty of morphine is I have lots of choices of how to give it. I can give it IV, which is fine, 0.1 milligram per kilogram to get the right dose on board, and that's a really important part of giving morphine because you have to dose it properly. I can't tell you how many times I hear somebody say, ooh, I'm gonna start with 2 milligrams of morphine.
I always ask, are you treating a neonate? Because that's the correct dose for a 20 kilogram person.
Like wrong, and I get a lot of pushback when I order 8 to 10 milligrams of morphine, but when you look at weight-based dosing, that's the appropriate dose. Now, over IV, I'd actually prefer to give the medication orally, and not by pill, which is fine also, but actually sublingual. We have a sublingual liquid. The trick on that one is you have to multiply by 3 because it's a 3-to-1 ratio from IV to PO. And so these patients are getting 15 to 20 milligrams of sublingual morphine. It lasts longer than IV, but it works faster than a pill form. And so it's really that sweet spot. And even if somebody's nauseated but not actively vomiting, it still works for them because all they have to do is hold this liquid under their tongue for a few minutes.
And it's not a gross tasting liquid, or I guess if you're getting morphine, you don't really care.
It doesn't taste good, but it doesn't taste horrible. You know, it just kind of is.
Okay. Andy, what's your go-to?
It's similar to Drew's, where it's can they tolerate oral or not? If they can, oral morphine's great. We have an immediate release tablet that dissolves under their tongue in our pharmacy. So I give that, and if they need IV, I give morphine dosing similar to Drew. And then there is the other caveat of, is this an orthopedic injury? Because if it is, I'll typically bypass morphine and head over and give some fentanyl that's weight-based.
That's an important point. So if it's severe pain, right? My femur's sticking through my leg, I have an acute abdomen, I have to get the pain down to a controllable level, then I give 1 dose of fentanyl. And then I switch to morphine, or I also have sublingual OxyContin, so I'll give that also as an alternative because some people don't like morphine. They say they have an allergy to it, whatever. And that's fine. And the dosing on that is easy because it's 5 or 10 milligrams.
I don't disagree with your approach and your dosing, but my first line is going to be hydromorphone for these patients. And this is my hot take, and this is why. I can't get a nurse to give 10 milligrams of morphine to any human being. It doesn't work. So I do this weird bargaining. We'll give them 2, give them 4, and maybe we'll get to 10 milligrams total after a couple of rounds. So I can get the dosing right. And when you look, the morphine equivalence for 1 milligram of Dilaudid is something 10 to 12 of morphine. So I'm hitting that sweet spot of 0.1 mg per kg for an average 100 kilo adult. So I don't have to worry about the dosing. I think patients like it better. And I don't think that's a bad thing. There's an interesting study where they looked at healthy volunteers, which is a hell of a study to be enrolled in. And they gave the healthy volunteers either Dilaudid or morphine. And even when you dose it equivalently, the patients or the volunteers preferred Dilaudid significantly compared to morphine from a I feel better standpoint, and also the subjective side effects were generally positive, and they had more likability for the drug.
So the problem with that study is it was young, healthy people getting this medication, and what hydromorphone did is it made them high. They liked it because it truly made them feel good. That's not my goal when I'm treating pain. I'm not trying to make them feel good. I'm trying to take the pain away.
Yeah, hospital heroin's a great thing to give people. Never.
Well, so this is the thing. If you look at a lot of studies or a lot of papers that are out there that talk about hydromorphone, they say it's prone to abuse. If you click on the links and go down the hole, that's only coming from limited data that says it has a higher likability score. And when you look at the survey that's given to patients for this likability score, it's did you feel better when you got this medicine? Would you receive this medicine again? And would you give it to a family member? And so my worry is we hear that people like things. Like I got a root canal. I've had it with and without laughing gas. I liked it more with laughing gas. I think that there is a role for getting patients high. I mean, if your femur is shattered, you probably want to be a little bit high. And so I went for a long time never prescribing Dilaudid. And then I started to really dig into what is my goal here? And I think it is treat pain, but also I don't have a problem if you have an acute painful emergency getting you a little bit high. And I think the patients like it. I'm not sold that that leads to any more abuse than morphine or fentanyl.
Yeah, I think the problem is we don't actually know if the patients like it. We know in this study of young, healthy volunteers getting really strong opioid medicine that they liked it. But we haven't really done that study on the patients, but we do have some good data to say that fentanyl and hydromorphone are more lipophilic, which means they are going to the brain, they're going to places where you're getting beyond the mu receptor, right? They're working beyond what we're targeting with our opioid receptors and our opioid medication. And so it is truly giving you a euphoric high. And I'll tell you, it's anecdotal, and I admit that completely. But when I stopped using hydromorphone in my practice, and we got our emergency department away from the medication, about a year later, very rarely did anyone come in asking for a specific pain medicine. And on top of that, they were happy with the multitude of other options we had, where previously it was Dilaudid or bust.
Right. Is there a patient where you're going to use hydromorphone, or you just don't use it in your practice?
Well, we were talking about this last night at dinner, that the last time I used hydromorphone was when we were on a fentanyl shortage for intubated patients during COVID. And it's not that I won't use it, I just reserve it for very specific patients that I haven't run across. And those are typically patients who don't respond to morphine, don't respond to fentanyl, and are still in acute pain.
And I would actually argue that in the intubated patient, we shouldn't be using fentanyl, at least not after the first push. We should be using Dilaudid for pain control because it's longer acting. I mean, what nurse on a ESI-1 intubated patient that has other things going on has time to dose fentanyl Q 15 to 30 minutes, which is what you actually have to dose it for good analgesia? And if we're doing all this properly, and we're getting beyond the talk of hydromorphone here, but we're bringing our sedation medication down because our paralytics worn off, and we need to make sure we have good pain control. That is the one scenario where I'm okay with Dilaudid.
Do you use ketamine for pain?
Absolutely.
Yes.
People like it. People get high off ketamine. How is hydromorphone different for you?
You know, I've never had somebody come in asking for ketamine.
Yeah. I had a guy, I thought that I'd really saved the day. He had end-stage pancreatic cancer, had come in for Dilaudid every day. And I gave him ketamine, and he came out of the room and hugged me and said that this is the best he'd felt since he was diagnosed with cancer. I told my kids and my wife, like, look what I've done. And he came back every day for the next 5 days asking for ketamine. So I think the ketamine seekers are out there. They're certainly less prevalent than other medications.
They are. And the thing with ketamine is we have an alternative to hydromorphone with other opioid medications. We don't really have an alternative to ketamine, right? It's a different mechanism. It's a different set of receptors. It works in a different pathway. And oftentimes we're using that when it's refractory to opioid medication, or there's a contraindication to opioid medication, and that's where we have to go. My argument is we don't ever have to go to hydromorphone in the awake, non-intubated patient because I have so many other better options for pain control that I don't have to worry about potentially getting the patient high and liking the medication too much.
And I think that's where I have a problem with the one-size-fits-all, oh, they need Dilaudid, because some of these patients I don't want high. I don't want my little old lady who's delirious that broke her hip to get higher than what she already is from her fever or UTI, or the young kid that decided to do PCP and other things and dislocated his shoulder. They're already high enough. And so it's the one-size-fits-all approach to Dilaudid, knowing there's other things that patients come in for, is one of my other reasons why I don't usually go to it.
Okay, let's do a quick show of hands. If you are someone who rarely or never uses Dilaudid, let's see your hands. All right.
Oh, come on, there's more of you out there. What the heck?
If you're someone whose first line is Dilaudid, I'll stand with you. There we go. That's better than I thought it was going to be. You made the shirt.
There's
four of you.
4 hands.
They were very quick to put their hands up.
They were. It was aggressive for.
I think we're all doing a good job. Some of us may be doing a better job, but I think it's an interesting debate, and we've seen that pendulum swing. I mean, when I trained, this is a really bad name for it, but we had the starter pack. It was a blister pack of 5 milligram oxycodone and 5 tablets, and you could verbally order it. So we'd be like, oh, he's got a cold, toss him a starter pack. You know, as the pendulum has swung back and forth, I think we're finding our footing.
Where did you train?
Okay, I'm not trying to drum up into a business for that place, but yeah, I think we've learned lessons, and I think this practice variation for something we do so often is really interesting. So I've not won you over, but I've got my people out here, so I feel better now.
I'm glad you have 4 of them.
There we go, perfect. Yeah. All right, day 3 of Essentials, let's do it.
Yep.